Good morning to all of you. First of all, I would like to thank the Kennedy Society of Medicine for giving me this wonderful opportunity to speak in front of the distinguished audience. In fact, the topic of endocrine hypertension, physician's perspective, you might wonder why a physician is talking about endocrine hypertension. And the reason why I selected this topic is due to Professor Chamara Dalugama's influence, because both of us did a hypertension symposium and I did this topic in that symposium. So Professor Chamara Dalugama wanted me to speak on this topic in this audience. So thank you, Chamara, for giving me this opportunity. So my topic would be endocrine hypertension, a physician's perspective. So during the next 45 minutes, I will take you through the journey of some basic concepts about hypertension, where I will be covering about the present awareness and the fatal consequences of not treating hypertension, and then little bit about circadian rhythm of blood pressure during the day and the importance of ambulatory blood pressure monitoring, and little bit about resistant hypertension. And then with 4 clinical scenarios, I will touch upon endocrine hypertension. And I'm very happy that my friend and colleague, Dr. Charles Anthony Pillai, is here. So at the end of the lecture, if I get stuck with any questions, I'm pretty sure Charles will help me out. Right. When we talk about hypertension, I would say it's a silent killer. Why I say it's a silent killer is the fact most of the time, unless it's a secondary cause, most of the time in primary hypertension or essential hypertension, patients are asymptomatic. So as clinicians, we find it difficult to convince the patient regarding the importance of treatment, because even if the patient's pressure is high, when we say the patient needs to be treated, they don't care. They will say, doctor, I don't have headache, I don't have dizziness, so why should I take treatment? So because hypertension, unlike diabetes, most of the time doesn't have any significant symptoms, physicians face it as a real challenge to convince and treat the patient. So because of this asymptomatic nature, uncontrolled hypertension will lead to fatal outcomes. So in the ETU setup, we see a lot of patients coming with fatal ICH. The sole reason why they are coming to the ETU A&E department is solely due to uncontrolled blood pressure. And then we see a lot of patients on dialysis long term due to uncontrolled blood pressure, and people get acute kidney injury due to blood pressure. And then ST elevation MI, acute coronary syndrome, the cardiovascular mortality, not the morbidity, is most of the time due to uncontrolled hypertension. And then surgeon's perspective, peripheral vascular disease and leg amputation is due to uncontrolled hypertension associated with cigarette smoking. And then acute left ventricular failure itself is a common manifestation of uncontrolled hypertension. So being an asymptomatic disease, not getting treatment, this will lead to fatal consequences like ICH, acute LVF, acute kidney injury and CKD, TVD, as well as even blindness. So students and postgraduate trainees, there are stages of retinopathy, but most of the time patients don't go for visual examination, and then finally they can even end up with blindness. So just by not controlling just not controlling blood pressure, the patient will end up in deathbed, or that will lead to significant morbidity. So this slide is very important. This is a meta-analysis done over a period of 65 years in India. Even though this study is depicted in 2013, this very important take-home message. If you look at both the rural and urban population in India, the prevalence wise, it says overall prevalence 29, but that is in 2013. But now the prevalence of hypertension has gone up somewhere between 35 to 40. But the important part here would be the first bit. On average, the awareness about hypertension on average, both rural and urban, is around 35%. So the patient's awareness about this disease entity is very poor. Unfortunate or sorry to say, there are a lot of symposiums related to diabetes and dyslipidemia, but even as NCD prevention programs, even consultants, we are very much less interested in educating patients about hypertension when comparing to dyslipidemia and diabetes. So I think we should take the lead and make sure the people have adequate awareness about this deadly disease. And out of this 30% of people who have awareness, only about 30% seek treatment, which is also alarming. So the second bit, only about 30% of the population who have the awareness about hypertension, they seek treatment. That is solely due to the fact they are asymptomatic. So they are not interested in taking the treatment. And out of that population, only about 15 to 20% of persons have controlled blood pressure. So this is very alarming. Out of all the slides, I think this is very important for healthcare persons as well as patients. The awareness, treatment and control is about 25 to 30%, which is very alarming. So what are the reasons for this low degree of awareness, seeking treatment as well as control? Again and again, I'm highlighting the asymptomatic nature of hypertension. So patient is not interested. So why should I take treatment? Second one is very important for the audience here. It's the clinician's inertia. What is inertia? Tendency to do nothing or remain unchanged. So we are kind of have an ego and we don't learn new things, and then we wait. We don't treat the patient. So we are very inactive sometimes in initiating treatment. Sometimes as clinicians, we prescribe fish oils, vitamin E for hypertension. Some I have seen in the primary setup. Some doctors, they prescribe vitamin E, fish oil, and they tell the patient, you exercise and cut down on alcohol and diet. There is no need to take treatment for hypertension. So it's the clinician's inertia. And then the patient's inertia. They are very lethargic. They don't want to take treatment, not interested. So both parties, the inertia part plays a significant role. And then the myths. In our community, weddings, funerals, trips, all these gossip. They will say you take garlic, you take karapincha, whatever. So they rely on this other stuff rather than taking medication, because they think by taking medication they can develop side effects, because side effects are very minute, less harmful, but because of the myths. And then the social media propaganda, sometimes even some of our doctors, certain diet methods, they promote without promoting taking Western medication, and then most of the people seek for complementary and alternative methods to control their blood pressure. So all these reasons play a part, but as clinicians, even though we can't control all the other stuff, our inertia, we have to come out of it. So we should be active, we should be proactive to treat our patients. So quickly I go through about this. Everybody knows by reducing the blood pressure, we can prevent stroke death, coronary artery disease, and heart failure. Right. Again, this is a very important slide. What this says is the measurement of blood pressure is the clinical procedure of greatest importance, but that is performed in the sloppiest manner. So we pay particular lot of attention to complicated things, but as physicians, sometimes the way we measure the blood pressure is totally wrong. So there are so many factors why we are not doing this properly. It's a very simple thing, but we are not doing it correctly. It could be due to the machine error, because sometimes we get older sphygmomanometers. It could be due to the illumination. In a dark room, we can't read the exact values. But most of the time, as clinicians, we do make mistakes. So what are those mistakes? So when we are measuring the blood pressure, the patient comes to our channeling room. We are in a hurry to see patients. We have a target. This hour we have to see this much. So we are rushing things. So we we ask the patient to sit quickly, and then without asking anything, okay, mata pressure, we quickly check the pressure. So that is wrong, because you have to have a chat with the patient at least 5 minutes. And then when you are checking the blood pressure, the correct arm cuff should be there. Patient should be relaxed, legs apart, with the back supported in the proper chair. And then both parties should not talk. But what happens most of the time, especially in our local government clinics, we shout at patients. Pressure value at the. So that kind of attitude should be changed, because both the doctor and the patient should not talk, and we have to measure the blood pressure, and then we have to take 3 readings, and we have to take the average of the last 2 or the third one, not the first one. Because when we check the blood pressure for the first time, patient, they are coming with a lot of hardships. They would have come in a 3-wheel, financial issues, social reasons. They come with a stress, and we give additional stress, and we measure the blood pressure, and without thinking, we escalate on therapy. So when we are measuring the blood pressure, this is there you can Google and read. Remember, junior doctors especially, when you are measuring the blood pressure, there is a method. Do it properly. And then prior to measuring the blood pressure, half an hour to 1 hour before, patient should not consume tea or coffee. Previous day, he should have not taken alcohol. Proper sleep. Should have taken the main meal before checking the blood pressure. And then most important part is you give respect to the patient, talk to them, spend some time, and then check the blood pressure. And when you are measuring the blood pressure, check in both arms, take the higher value, and take the third one or average of the last 2. Quickly, when we take the blood pressure for 24 hours, we know that daytime blood pressure is this, but in the night when we are sleeping, the pulse rate goes down, we get a bradycardia. Same time, the pressure also drops. So if you see the dipper, this is the dip. So in the night, the blood pressure drops by 10 to 20%. That is a normal phenomenon. But as physicians, when we are treating patients, there is 2 categories. One is non-dippers, the dip doesn't happen, or there's a reverse dipping. Even though this doesn't show, sometimes in the night the pressure goes up. That is called reverse dipping. And then there's another extreme degree of extreme dippers. So when we are treating patients, we should know there are few categories of people who get reverse dipping. That is, the pressure goes up in the night, and also extreme dipping. So this is very important in treating. Otherwise, if we give in an extreme dipper, if we give too much of antihypertensives in the night, the nocturnal blood pressure will drop dramatically, and early morning they can get a MI or sort of any fatal outcomes. And then the reverse dippers, if we don't give the night blood pressure, they can get MI on the other extreme. So the take-home message would be, we have to identify the non-dippers and extreme dippers. Extreme dippers, you either stop or reduce the night dosing, and then reverse dippers, you give the night dose. That is very important. Otherwise, ETU setup, most of the time we get early morning MI and strokes, most of the time due to this basic physiological process. So that's why there is a very simple test called ambulatory blood pressure, where you can do it in Kandy. It costs you 3,000 rupees. The cardiology technician, he will put a small cuff with an attached small cell phone like material adjusted to the belt, and then you carry out your normal activities, and then you get the 24-hour reading, and then you can get an idea about whether this person is having nighttime dipping, reverse dipping, what about the 24-hour blood pressure recordings, average, and then as clinicians we can decide about blood pressure treatment. Right. And then in the basic pathophysiology, my last slide would be about resistant hypertension. because this is important when we are talking about endocrine hypertension. Resistant hypertension, by definition, is the blood pressure which remains above the standard amount, 140/90, despite taking 3 antihypertensive groups of different classes, which should include a diuretic. So diuretic means not fusimide, it should be hydrochlorothiazide or thiazide diuretic. So if the patient is on 3 group of drugs, including a diuretic, despite taking maximum doses of 3 classes, patient's compliance is good. The method in which we are measuring the blood pressure is good. And then still if the pressure is high, that is resistant hypertension. So don't label somebody as resistant hypertension without giving optimum doses of that drug. So how do you know about the optimum dose? Use the BNF. So I hardly see people using BNF. So use BNF to get an idea about the maximum doses of medication. And then to label resistant hypertension, as clinicians, you should measure the blood pressure correctly. Otherwise, you will be in trouble. Okay. So actually I have covered the first part of the lecture where I talked about the importance of controlling the blood pressure. Unless if you don't control, what are the fatal outcomes? The correct way of measuring the blood pressure, the 24-hour circadian rhythm of blood pressure, and then the importance of ambulatory blood pressure monitoring, as well as what is resistant hypertension. Okay, so I will go to the important part of my lecture. So can I ask from the audience, what is the most common cause of endocrine hypertension in clinical aspect? Not the consultants, juniors. Can you tell me what is the commonest endocrine cause of hypertension? You have to talk, otherwise telepathy, I don't know. You have to talk. What is the commonest cause of Ishwak? What is the commonest cause of endocrine hypertension? So his answer is hyperaldosteronism. Agree or any other suggestions? Any other endocrine disorder, common cause of secondary hypertension? Somebody says Cushing's. What are the other things? Okay, so what is blood pressure? It's the output of the byproduct of increased cardiac output and peripheral resistance. So cardiac output depends on the stroke volume and the heart rate, whereas the peripheral vascular resistance depends on so many mediators like aldosterone and angiotensin 2. So controlling blood pressure is not easy in clinical practice. So just don't give some antihypertensive as you like, because you should understand the basic pathophysiology. Even though there are so many contributory factors causing hypertension by mediating through systemic resistance, in a way that is good, because if you understand the basic pathophysiology, you can use the appropriate group of medication. So basically, blood pressure equals cardiac output into peripheral vascular resistance. So now I come to this topic of endocrine hypertension. When to suspect endocrine hypertension? So in a medical clinic, we see hypertension, one clinic about 100 to 200 patients. So are you going to suspect hypertension in all these patients? No. So when are you going to suspect endocrine hypertension? Number one, young patients, basically less than 30 years, without family history of hypertension. So even sometimes with family history of hypertension. If you are dealing with a young patient with hypertension, okay, you think this could be endocrine. But saying that the commonest cause of secondary hypertension is renal, so don't forget about renal causes. Here I am talking about endocrine. So if you see a young patient with hypertension, could be endocrine. Then hypertension with hypokalemia, severe hypertension, resistant hypertension, and then if there are any positive family history of endocrine disorder like Cushing's, Pheochromocytoma, neurofibromatosis. And then when you look at the patient, if there is any obvious endocrine features like acromegaly, Cushing's, and then hypertension presenting with deadly symptoms. But the take-home message is, if you are dealing with a young patient, severe hypertension, resistant hypertension, positive family history of endocrine disorder, you have to think this could be endocrine hypertension. As one postgraduate trainee said correctly, out of all the endocrine hypertension, primary hyperaldosteronism is the commonest, even though Cushing's and Pheochromocytoma and acromegaly are more fashionable diagnosis. I won't say fashionable. Postgraduate trainees' favorite topics. Primary hyperaldosteronism is the commonest cause of endocrine hypertension. So, when you are dealing with the endocrine disorder and when you are managing those patients, there are some basic principles. You have to make the biochemical diagnosis before going into imaging, because if you go to imaging, one is cost, second one unnecessary radiation, and third thing, you find incidental. So if you do pituitary and adrenal imaging without biochemically confirming, you will get incidental like pituitary and adrenal. So you don't image the patient unless you make a biochemical diagnosis first. And then the third thing is, in endocrine disorders, if it's a hyposecretive disorder, you do the stimulation test. And if it's a hypersecretive disorder, you do the suppression test. The fourth one is very important. Always when you are interpreting any clinical condition, importantly in endocrine, you look at which lab, what is the assay, and what are the units. And then always keep the clinical scenario in mind. So make the biochemical diagnosis, then go for imaging, think about stimulation and suppressive test, look at which lab they have done the test, what is the assay, and what are the units. So these are very important. Right. When we are imaging in endocrine, MRI, we go for the brain because it's a smaller organ with better detail with MRI. Whereas adrenal, because of the fat tissue and the movement, we do the CT. Right. But coming back with all these biochemical investigations and imaging, still back to old medical school, history, examination, clinical suspicion and appropriate investigations should be carried out in correct order. Otherwise, you will either overdiagnose or underdiagnose. Right. Now I will come to my first case scenario. This is a 28-year-old young bank executive presented to A&E department with headache, dizziness and paresthesia for last 2 days duration. He also complains of polyuria and polydipsia for 1 week. So 28-year-old young person, headache, dizziness and paresthesia for last 2 days, polyuria and polydipsia for 1 week. By looking at this history, you might think he might have diabetes as well. And then 2 siblings have had hypertension for last 1 year and 6 months respectively, but siblings' blood pressure poorly controlled despite being on multiple drugs. So there is a significant young family history of hypertension and patient presenting with headache, dizziness and paresthesia with osmotic symptoms of polyuria and polydipsia. On examination, obese but no obvious Cushingite features, pulse normal, blood pressure 180 by 120, shifted apex, retina there are hypertensive changes, and muscle power grade 3 in both upper and lower limb, all muscle groups. Full blood count normal, HbA1c normal, ECG left ventricular hypertrophy, chest X-ray cardiomegaly, liver function normal. So what is the most important investigation we are missing? Sorry? Serum electrolytes, yes. So sodium 146, potassium 3.1, alkalosis with urinary potassium elevated. So here the diagnosis is hyperaldosteronism. But still, even though we think, I will come into that why we came to this diagnosis, but basically this is hypertension with hypokalemia, with symptomatic hypokalemia, and ECG showed some U waves as well. So hypertension with hypokalemia, straight away you don't jump into aldosteronism, because it could be essential hypertension with diuretic, could be Cushing's, but this patient doesn't have Cushingnoid features, or it could be Pheochromocytoma, unlikely, but renal vascular disease is a possibility. So out of all these cases, somebody coming with hypertension and hypokalemia, you have to think of essential hypertension with diuretic usage. Diuretic means either furosemide or HCT, not aldosterone. And then primary aldosteronism and renal vascular disease and Cushing's. But Cushing's we have excluded by appearance, it doesn't appear Cushingnoid. So little bit about physiology. Aldosterone is produced in the zona glomerulosa outer cortex of the adrenal cortex, and it's a mineralocorticoid. This we all know. So aldosterone, it's secreted with the action of angiotensin 2, and it leads to sodium retention and potassium loss. Because of sodium retention, patient develops hypertension. Right. So we are talking about primary aldosteronism, in which you get more aldosterone, and due to the feedback you get less renin. So that is primary aldosteronism. But in secondary aldosteronism, due to so many causes, you get increased renin with increased aldosterone. So how do you differentiate both conditions? Aldosterone-renin ratio, which I will come into detail later. So if you think primary, so with all these clinical diagnosis or biochemical diagnosis, primary aldosteronism, with the help of aldosterone to renin ratio, then we know we are dealing with primary aldosteronism. Then we go for the imaging, because we have to differentiate between adenoma and adrenal hyperplasia, because the treatment is different. So don't get confused, simple. Somebody coming with hypertension and hypokalemia, exclude the other causes by history and clinical history and examination. And then always listen to the renal bruit as well, because renal artery stenosis can cause this picture. And then if you think this is primary aldosteronism, you do the aldosterone to renin ratio, you biochemically confirm that, and then you do the imaging, you do the CT adrenals to differentiate between adenoma and adrenal hyperplasia. Simple. So same thing. Why the patient gets higher polyuria and polydipsia is due to, and nocturia due to hypokalemia, and muscle weakness and loss of reflexes are also due to hypokalemia. So same thing, history, examination, investigations. So at investigation wise, you look at the serum electrolyte. First thing, hypernatremia with hypokalemia. You get hypomagnesemia, metabolic alkalosis, and then high serum aldosterone to low plasma renin, and then imaging and adrenal vein sampling. But there is a problem. Even though I say these things as a theoretical way, unfortunately, only 35% of primary aldosteronism, they will have hypokalemia. So there's a problem. So then you have to use your sensors and then take a proper history, family history, because primary aldosteronism, sometimes it's autosomal dominant. So you should have some sort of clinical suspicion also. Don't always look for hypokalemia, because rest of the 65%, they will not have hypokalemia. Right. So when you are doing the aldosterone to renin ratio, you have to correct the hypokalemia first. Otherwise, you will get false positive. Patient should take normal or high salt intake, and you have to stop certain medications which interfere with the assay of the aldosterone-renin ratio, namely spironolactone and beta blockers, because beta blockers act via the renin pathway. And then I told you, with the biochemical diagnosis, Then we go for the CT imaging. If there is adenoma, you do the surgery. If it's adrenal hyperplasia, you do the medical management with spironolactone or eplerenone. Comparing both, spironolactone is better than eplerenone potency and efficacy wise, but side effect profile, because of the androgenic and progesterone effects, eplerenone is better. But to get the clinical outcome pressure control, spironolactone is superior, but sometimes spironolactone causes gynecomastia and menstrual irregularities in ladies. So you have to be a bit careful when you are prescribing spironolactone. But adrenal hyperplasia, the better treatment is spironolactone comparing to eplerenone. So this is the CT where you can see the adenoma, which is a very small rounded lesion with fat tissue. So I will show you about Pheochromocytoma later. So adrenal adenoma, it's a very small rounded lesion, usually less than 1 centimeter. And this is the resected tumor, which is a very rounded, good looking, less aggressive with no necrotic or vascular regions in the tumor. Right? So why we are talking about primary aldosteronism? Difficult condition to diagnose, whereas Pheochromocytoma and Cushing's most of the time straightforward. But primary aldosteronism contributes to 5 to 10% of secondary hypertension and 30% of resistant hypertension. And it's autosomal dominant, so family history is important, but hypokalemia is seen only in 35%. So in summary, that is the most commonest endocrine disorder causing hypertension. History examination and clinical suspicion should be there. Serum electrolyte, if there is hypokalemia with hypotension, you exclude the other differential diagnosis. And then if you are thinking about primary aldosteronism, you do the aldosterone to renin ratio, and if it's high, and then before doing the test, you have to stop the beta blockers and spironolactone. You have to give adequate salt, make the potassium level normal, and then you do the assay. If it shows elevated aldosterone to renin ratio, you go for the imaging, and then if there is adenoma, you do the surgery. If it's adrenal hyperplasia, either spironolactone or eplerenone. But I think Charles will enlighten. Only problem is, I checked only with one lab, the aldosterone to renin ratio costs 60,000. So the cost is a problem. So we'll discuss at the end of the lecture. So doing aldosterone renin ratio, the cost is 60,000. Case number 2, a bit straightforward. I will rush through. 35-year-old mother of 2 presented with recent weight gain, headache, blurred vision, muscle weakness involving proximal muscle, and osmotic symptoms for last 1 month. Almost the same history, but there is weight gain with blurred vision, but muscle weakness and osmotic symptoms are there. But there is no significant family history. That's the difference, and the obstetric history is normal. On examination, patient is obese. Whereas our primary aldosteronism patient, he was clinical examination wise normal, apart from muscle weakness. But this patient has obesity, moon phase, acne, central obesity, EC bruising, striae, and proximal myopathy. So all the typical exam-oriented features are there. And then blood pressure 190 by 130. HbA1c 9, full blood count neutrophil leukocytosis, sodium 140, potassium bit low because there is some mineralocorticoid part also in Cushing's. ECG left ventricular hypertrophy. So this is the patient. So this is straightforward. This is Cushing's. You can see the moon phase. What is moon phase? When you look in front, you stand in front of the patient, you can't see the ear because of the preauricular fat. And then they will have acne, central obesity, striae, EC brucibility, proximal myopathy. This is typical of Cushing's. So this is textbook stuff. So what is Cushing's? Excess glucocorticoids, adrenal wise, in the adrenal cortex, zona fasciculata secretes glucocorticoid. But then, as clinicians, don't jump into endogenous Cushing's because in Asian setup, we are overusing steroids. So steroid usage is the commonest cause of Cushing's. So always exclude whether patient is on steroids, but sometimes you will get fooled. We will ask whether patient is on dexamethasone or prednisolone, but we miss the trick because most of the patients are on complementary and indigenous medicine, where it sometimes, not sometimes, most of the time mixed with dexamethasone and other steroids. So take a proper history. Don't rely only with the patient's story. Ask from the family members whether the patient is taking any sort of indigenous medicine. Right. So this is again through corticotrophin releasing hormone and ACTH, adrenal gland secretes cortisol. So what this says is either hypersecretion of cortisol could be in the adrenal or it could be in the pituitary due to excess ACTH. So there are two varieties of Cushing's, three actually. One is exogenous due to steroids, and then ACTH independent is the adrenal ones, whereas ACTH dependent is Cushing's disease, that is pituitary or ectopic ACTH. So very simply, I will tell you how to proceed with the investigations. You do a 9 AM cortisol, and if the 9 AM cortisol is normal, unlikely to be Cushing's, but if the 9 AM cortisol is high, then you have to proceed. So first, you take the history, exclude exogenous steroids, depression and alcohol, which all can cause pseudo-Cushing's or Cushingnoid appearance. If those things are excluded, you do a 9 AM cortisol. If that is normal, most of the time Cushing's excluded. If the 9 AM cortisol is high, you have to proceed with other investigations. Namely, you can do the 24-hour urinary cortisol or 1 milligram overnight dexamethasone test, or you measure the 9 AM and midnight cortisol, because normally the midnight cortisol is low, but in Cushing's, you lose the circadian rhythm. So out of these three, if two things are positive, then it's confirming that this is Cushing's. So you do the 24-hour urinary cortisol, you measure the midnight cortisol, and then the overnight dexamethasone suppression test. And if things shows Cushing's, then you confirm it to be Cushing's. And to differentiate between Cushing's disease, which is pituitary mediated, from adrenal or ectopic, you can either do the high dose or ACTH level. So bit complicated. For me also, it's difficult to teach you within a short time frame, but especially the PG trainees, go home and read. First, you confirm the 9 AM cortisol. If it's low, you exclude Cushing. If the 9 AM cortisol is high, you do the 24-hour urinary cortisol, midnight and 9 AM cortisol, or 1 milligram overnight. Out of those three, if 2 is positive, Cushing's, then you do the high dose or ACTH level to differentiate between pituitary and adrenal. Same thing. What happens is in pituitary, with the high dose, cortisol level comes down, whereas in adrenal and ectopic, the cortisol level will not come down. Same thing. So if it's pituitary, neurosurgeon, adrenal, again surgery, and then exogenous steroids, you stop the steroids. So simple. So you differentiate whether this is adrenal, whether this is pituitary, or exogenous or ectopic. Right. Third scenario, 22-year-old patient who is a mother of one presented to A&E department with severe dizziness, episodic headache, sweating and palpitation for last 1 week, and also complaints of loss of weight for 6 months and loss of sleep. LRMP 1 week ago, several episodes of episodic dizziness, palpitation and sweating for the last 3 months. Hypertension detected and on 2 groups of antihypertensive with good compliance. So patient is taking the medication correctly, young female, mother of one. But the problem is episodic dizziness, headache, sweating and palpitation for 1 week. What are the possibilities? PGs, Pheochromocytoma, but don't forget anxiety, hyperthyroidism, migraine and hypoglycemia also. Because apart from hypertension, if we are not talking about hypertension, these symptoms could be due to anxiety, could be due to hyperthyroidism, migraine, or hypoglycemic episodes. But then the family history revealed 2 siblings had difficult to control blood pressure, and there was some significant family history of solid organ malignancies, pancreas and liver. On examination, patient was anxious, pulse rate 120, blood pressure 200 by 120, cardiomegaly was there, but no renal bruise. So then you have to think of pheochromocytoma. So what is pheochromocytoma? It's the adrenal medulla tumor, all those things we spoke earlier, adrenal cortex. So pheochromocytoma is an adrenal medulla tumor where the medulla produces epinephrine and norepinephrine. Right. What are the symptom triage? They get sweating, headache, dizziness and palpitation with hypertension. But according to the literature, weight loss is a very significant feature of pheochromocytoma, possibly due to the excess catecholamine surges. So loss of weight, headache, sweating, palpitations, you have to think of with hypertension, pheochromocytoma. So what is the investigation? You either do the plasma metanephrines or 24-hour urinary metanephrines, and if it's high, that confirms pheochromocytoma. But remember one thing, with even simple stress, the metanephrines can go up. So if the metanephrine level is more than 2 or 3 times higher than the normal value only, we will think of pheochromocytoma. But then we have to go for the imaging. So what are the images? You do the CT to see for the adrenal tumor, and then there is a place for radionucleotide scanning as well. So you need the nuclear medicine help. So why we are doing the nuclear scan in pheochromocytoma? Because all these are sympathetic mediated systems. So you get paragangliomas, like when you have a tumor within the adrenals with pheochromocytoma, there is a higher chance of getting extra adrenal lesions as well. Something like carotid body tumors, sympathetic ganglia tumors along the blood vessels. So then when you diagnose pheochromocytoma, it's very important to go for the nuclear imaging as well. So there are certain medications interfering with the metanephrine assay, but the current assay methods, most of the medications doesn't interfere with the metanephrine assays. So comparing to the previous adenoma in cons, here in pheochromocytoma, the adrenal mass is very aggressive looking. It's a highly vascular, necrotic tumor in pheochromocytoma, whereas cons, it's a very small, benign looking, silent mass. And then you do the radionucleotide scan and you can see the hyperdense areas to be the gangliomas. So after making the diagnosis of pheochromocytoma, you can't wait. You have to treat the patient. So what is the treatment? You have to be very quick to direct the patient for the surgery. So as physicians, we have some important things to be done prior to hand over to the surgeon. So patient should be admitted 1 or 2 weeks before the surgery. And then the most important thing is you don't give beta blockers in pheochromocytoma to control the blood pressure, because the catecholamines acts via alpha, which is the predominant effect, and it causes significant vasoconstriction. But catecholamine acts via the beta 2 receptors in vascular wall to give vasodilatation as well. So if we block the beta effects by giving these beta blockers, the unopposed action of the alpha will make the vasoconstriction so bad there will be surge of blood pressure and patient can die. So never ever give beta blockers in pheochromocytoma, but you give alpha blockers. The recommended one is phenoxybenzamine, but cost and availability wise, sometimes we go for prazosine. And then prior to the surgery, the most important fact is for 1 to 2 weeks, we have to ask the patient to take about 3 to 5 liters of fluids every day and significant amount of salt prior to the surgery, because when the tumor is removed, with the sudden drop of blood pressure, the patient can die due to the depletion of the intravascular volume and the vasoconstrictor effect. So prior to the surgery, we have to make sure the patient's fluid status and salt status is optimized. So prior to pheochromocytoma surgery, you admit the patient 10 days before, you give alpha blockers and control the blood pressure. You give adequate amount of water and salt to make the intravascular volume more to prevent fatal consequences of the surgery. And then little bit for the PG trainees, in pheochromocytoma, always think about the association with neurofibromatosis. Look for Caffioli patches, renal artery stenosis buoys. Then little bit about von Hippel-Linares syndrome, where you can get renal cell carcinoma, cerebellar hemangioblastoma, and pancreatic tumors. MEN2, where you can get hyperparathyroidism, pancreas, and adenomas. And then think about paragangliomas, which could be malignant, and carotid body tumors also. That is the importance of doing the MIBG scan, because you just don't operate the adrenal tumor and wait. You have to do the radionucleotide scan to see whether there are hidden gangliomas or carotid body tumors. And genetic studies do play a role when it comes to von Hippel-Linares and neurofibromatosis. So pheochromocytoma, deadly disease, not as common as primary aldosteronism, but you should know what to do and when to do and how to prepare the patient for surgery. Last case, this is not a case scenario, quickly I will go through. Obvious acromegaly, patient presented with hypertensive symptoms and diabetic symptoms, and then everything is in the textbook. Soft tissue enlargements, patient will come and say, my voice has changed, I'm having snoring, my limbs and face has become bigger, comparing to the older photos I look big, arthritis, and then symptoms of hypertension and diabetes. So what is acromegaly? It's a pituitary mediated tumor where, due to the excessive growth hormone acts via the insulin-like growth factor secreted from the liver. So in acromegaly, clinically you get two things. The growth-related outcomes are due to the insulin-like growth factor, whereas the tumor, due to the compressive nature, it causes bitemporal hemianopia, optic nerve compression, cranial nerve palsies, and hypopituitarism. And acromegaly is associated with high degree of cardiovascular mortality and obstructive sleep apnea and colonic neoplasia. So what are the blood tests? You can either do growth hormone levels or insulin-like growth factor. And as I told you, hypersecretion conditions, you do the suppression test. So you give the oral glucose and see whether the GH reduction happens. In acromegaly, it doesn't happen. And then you do the visual perimetry also. And ultimately, you do the pituitary MRI. Here it's important. You make the biochemical diagnosis and do the pituitary MRI. Otherwise, you will treat for an incidental hormone. And then drug-wise, somatostatin analogs or growth hormone receptor antagonist or dopamine receptor agonist. But ultimately, transphenoidal surgery. But saying all these conditions, never forget hyperthyroidism and hypothyroidism. Hyperthyroidism is associated with systolic hypertension, whereas hypothyroidism causes diastolic hypertension. So, in summary, when you are dealing with hypertension, as clinicians, it's our duty to educate the patient. Not only educating the patient, we also have to educate ourselves. Because prior to the lecture, one of the consultants said, why you are talking about endocrine hypertension? Everything is essential hypertension, which is not the truth. So we should know a little bit about secondary causes of hypertension, and we should measure the blood pressure correctly and carry out the appropriate biochemical confirmation before going for imaging. Otherwise, you will treat for incidental lomas. And then you should know about the lab assay units and price of the test. And then with the appropriate imaging, you treat the patient. Thank you.